hematology, oncology, pathology, non-Hodgkin lymphomas. All right, so for non-Hodgkin lymphoma, we have multiple subsets of this, so we're going to just dive right into it. The first thing that we have to understand is that they're separated into neoplasms of mature B cells compared to neoplasms of mature T cells, okay? So the first thing that we're going to be talking about is the neoplasms or cancers of the mature B cells. And the first subset is Burkitt lymphoma. Burkitt lymphoma is probably the most high yield out of all these, but pretty much all non-Hodgkin lymphomas are high yield, so pay attention to these. Once again, before I go right into it, I would definitely recommend watching the sketchy videos on these because it's really, really helpful to help you memorize each of the subsets. So to begin, Burkitt's lymphoma, it occurs in adolescent or young adults, but I wouldn't pay too much attention to the age for our non-Hodgkin or Hodgkin lymphomas, okay? But what we have to know for sure is that it's a translocation between chromosome 8 and 14 of the c-Myc gene, which is on chromosome 8, and the heavy chain Ig, okay, light chain, for 14, all right? So if you ever see this, translocation of 814 with c-Myc, you know that you're dealing with Burkitt lymphoma. They like to ask about the translocations, and I'm going to make a translocation video because of how high yield it is. Now, what they love to ask as well is that they'll show you a starry sky appearance on histology, okay? And that is specific for Burkitt lymphoma. If you see large sheets of lymphocytes with these small light cells, those are macrophages. Those are the stars of the starry sky. Those are our macrophages, okay? And that is highly associated with Burkitt lymphoma. So you have to understand what the starry sky appearance looks like on histology and make sure you can recognize that. It's associated with EBV, Epstein-Barr virus, just like majority of all other cancers, but this one's highly associated with EBV. And what they like to ask is a child that has a jaw lesion is usually the endemic form, okay, seen in Africa for Burkitt lymphoma, because there's multiple forms of Burkitt lymphoma. One that they like to ask is one with a jaw lesion, okay? It's specific for Africa, and it's going to be also associated with Burkitt. It's a type of Burkitt lymphoma. If you see a pelvic or abdominal mass, that's going to be the sporadic form, which isn't as high yield, okay? Moving on to diffuse large B-cell lymphoma. There really isn't too much that you need to understand here. All you have to know is that there's a mutation in both BCL2 as well as BCL6. And we discussed, BCL2's role in the pathology videos to an extent. So just make sure you go and watch those and understand what BCL2 does. But for diffuse large B-cell lymphoma, not as high yield, just understand it's BCL2 and BCL6, okay? Now, follicular lymphoma. Follicular lymphoma, once again, a new translocation. It's going to have translocation 14 and 18, which is, once again, 14 is the heavy chain Ig, and 18 is BCL2, okay? For follicular lymphoma, they like to show you what the follicles look like. So if I were you, I would look up follicular lymphoma, see what it looks like on histology, and then be able to define that when you're going to take an exam, because they love to show that. It presents with a waxing and waning course that's painless, okay, with lymphadenopathy. So waxing and waning painless lymphadenopathy is something that they really, really like to talk about. Once again, we see that translocation of 1418 involves BCL2. And what do we know about BCL2? Once again, we're going to discuss it in the pathology videos, but BCL2 normally inhibits apoptosis. So if we don't have BCL2 doing its normal job of inhibiting apoptosis, it's going to be constitutively active. So it's going to constantly inhibit apoptosis. And so if it's constantly active, not inhibited, it's constantly activated because it translocates with the heavy chain Ig, that means that we will never be able to actually do apoptosis because we're constantly inhibiting it via BCL2 being activated, okay? That might have been a little bit confusing, but we'll talk about in the pathology videos. Next is mantle cell lymphoma. All you got to know is that it's translocation between 11 and 14, and that chromosome 11 is going to be the translocation of cyclin D1 with the heavy chain of 14, okay? Next, marginal zone lymphoma is just translocation 11-18. That's all we really need to know. And then lastly is primary central nervous system lymphoma. What they like to talk about is that we have to highly consider EBV infection, okay? Because it's associated with both EBV as well as HIV and AIDS, okay? So they love to ask this question, primary central nervous system lymphoma. If you see that there's EBV cells, then you know that it's going to be primary central nervous system lymphoma, okay? It's considered an AIDS-defining illness, and it's going to have different presentations. So it might be confusing when you first read about it. But the way that they will present is that they're going to give you an AIDS patient, and they're going to show you that there is some type of lesions within the brain. And the way that you have to differentiate it from is with toxoplasmosis. And how do you differentiate it from toxoplasmosis? Is the presence of EBV, of Epstein-Barr virus, Okay, if there's the presence of Epstein-Barr virus, then you get rid of toxoplasmosis on your differential and you put primary central nervous system lymphoma. Okay, they like to ask questions on that, so be aware. So that's all of our neoplasms of mature B cells. Just real quickly, Burkitt lymphoma, T814 with CMYC and starry sky appearance with that endemic form in Africa having the jaw lesion. Diffuse large B cell lymphoma is mutations in BCL2 and BCL6. Follicular lymphoma has T1418, which is BCL2, and that normally inhibits apoptosis, so it's going to be constitutively activated. So we're going to have constant inhibition of apoptosis, and it has waxing and waning lymphadenopathy. Mantle cell lymphoma is T1114 with cyclin D1. Marginal zone lymphoma is T1118, and primary central nervous system lymphoma is EBV related with HIV and AIDS, with these ring-enhancing lesions, or maybe not ring-enhancing lesions, just lesions in the brain that might look like toxoplasmosis, but you know the difference if you are given that there's EBV infection. Okay. Next and lastly, which is not as important at all, very low yield, but the neoplasms of mature T cells is the adult T cell lymphoma. I'm just going to bring it up just for so you have a full idea of what is occurring. It's caused by HTLV, which is a virus, okay? And all you really need to know about it is that it can cause lytic bone lesions and hypercalcemia, okay? That's all for non-Hodgkin lymphomas. If you have any questions, I would once again refer to using Sketchy, but you can ask me anytime.